Hello. Good. Can anybody hear me? I don't know if it'll be mic'd or anything. Can y'all hear me? Okay, if you in back can't, just let me know. Speaking loudly is not a weakness of mine. Like I said, I've practiced over at OU at Kimonka. I actually went to medical school at OU and then did my pediatrics and then training in Dallas at UT Southwestern, and then did 3 years of pediatric hematology oncology training there before coming back up here in 2010. So this will be sort of geared towards a kind of a primary care provider's guide to identifying and treating childhood cancer. And so the objective of this talk, we'll go over briefly. So to recognize basics about the incidence and prevalence of cancer in children. Again, a brief basic understanding of the cure rates of childhood cancer with current therapies. I know what are the common forms of cancer that we see in children, as well as the common presenting clinical manifestations. In primary care, you're going to be on the front lines. A lot of these you're going to be seeing these kids and making referrals to specialists. As well as understanding the basic approaches to diagnosing and treating cancer in children. So if you do find out that one of your children or your patients has cancer, you can give them at least an idea about what the oncologist might tell them. And then understanding common complications related to cancer therapy as well. So, although cancer is rarer in children than adults, it's still the leading cause of death by disease beyond infancy among children in the United States. In infants, it's congenital anomalies. In 2017, we estimated about 16,000 children and adolescents that are under the age of 20 will be diagnosed with cancer, and about 2,000 children a year will die. So, cure rates for childhood cancer have improved over time. In the mid-70s, only about 50% of children who were diagnosed with cancer were 5-year survivors. Now, we're up to 80%. It's a vast improvement. For some cancers, the improvement rates have been a lot more drastic, as we'll kind of talk about. For some of them, the improvements have been moderate or minimal, if at all. So it's important that, while surviving cancer is a good thing, these children and adolescents who've been treated need regular follow-up care as well for the rest of their lives, because there are increased risk for other side effects due to chemotherapy, surgery, radiation therapy that can sometimes occur many years after their treatment. And right now, there's somewhere around 350 to 400,000 childhood cancer survivors in the U.S. So this graph just basically shows a general distribution of the common cancers we see in children. So leukemias as a group make up a substantial amount of childhood cancer. Brain tumors as a group is our second most common cancer in children. Lymphomas is third, and then we have several kind of unique tumors like neuroblastoma, lung tumor, as well as other like soft tissue and bone tumors. Those are very different than in adults, where you have a lot of, like squamous cell carcinomas, like due to like lung injury from smoking, like lung cancer, and like the ovarian cancers and the breast cancer. So we'll start talking about leukemia, since it's our most common cancer that we see in children. So leukemia starts in the bone marrow, where you have one precursor cell inside the bone marrow that doesn't mature properly. It stays in this immature state. It's not regulated, and its growth is in an unregulated fashion. And it winds up just kind of overtaking the space inside the bone marrow, and it doesn't leave any room for normal blood cells to grow and develop. And so these cells, sometimes we call them blasts. They expand inside the bone marrow, and then can go to other parts of the body and compromise function. In children, the most common leukemias we see are what we call acute leukemias. So acute lymphoblastic leukemia, or ALL, and acute myeloid leukemia, AML. We do see some chronic leukemias, and we also call myeloproliferative disorders in children, but adults do see chronic leukemias and myeloproliferative disorders a lot more frequently. So it's important to know there's some children who have predisposing risk factors for developing leukemia. One of the biggest, most important ones is trisomy 21, or Down syndrome. children who have Down syndrome have a 20-fold greater lifetime risk of developing leukemia compared to other children. For ALL, it's about 12 times the general population. For AML, it's almost 50 times the risk. As well, there's some studies that show that siblings who have leukemia, one of their other siblings may have a slightly increased risk of leukemia over the general population. But we concern ourselves more with monozygotic identical twins who have a sibling that's diagnosed at less than 6 years of age. So a very young child who develops leukemia, if they have an identical twin, the identical twin has an increased risk of up to 25%. We know for like infants, like babies that get diagnosed with leukemia, if they have an identical twin, they're like less than a year of age and get diagnosed with leukemia, it actually is almost 100%. So there's probably something like in utero from that happened, and that they both have identical DNA, maybe increased risk. There are also some other genetic disorders that if you see patients with them, that you have to think about screening for leukemia, and they may have their own kind of best health practices screening. So neurofibromatosis, which is like a tumor suppressor malformation, Li-Fraumeni syndrome, which is another tumor suppressor malformation, and then Fanconi's anemia, which is associated with problems with DNA repair, and that's associated with leukemia as well as other cancers. So how's leukemia progress? So often we started, the most common presenting sign we see is bone pain and joint pain. As the bone marrow cavity gets filled up, it causes pressure on the bones, particularly in the legs and the hips. So sometimes you may see a kid who's previously active and running around, who's not walking anymore, who's having a lot of pain, especially like in the middle of the night. Due to problems with anemia, children may be pale, may be tired. Older kids often complain of nausea and headaches. Due to thrombocytopenia and coagulopathy, you may have bruising, petechiae, and easy bleeding. And fever is very common. Sometimes this is due to their immune system not working well, since they may have more leukemia cells than normal cells, and they can get infections. But also, a lot of this is these leukemic cells secrete cytokines that trigger fever. As leukemia cells wander out of the bone marrow, they can cause organomegaly like in the liver and spleen, and large lymph nodes as well. And some kids also will get gingivitis and gingival hyperplasia. So for labs, and some of you who worry about acute leukemia, the CBC is your go-to screening test. In general, we see anomalies in all three blood lines. So we see anemia, thrombocytopenia, and then something abnormal with the white count. It can be very high or it can be very low. You may also, in the differential, you may see circulating blasts, or you may not. You may just see kind of abnormal proportions with a lot of neutropenia, but you may also see blasts. Once in a while, you might have a kid who has leukemia but has a normal CBC, but they have some of these other kind of concerning factors, like with unexplained fever, bone pain, big organs on exam, and big lymph nodes, and they may have not just picked critical mass where you notice it on the CBC yet. For kids who have acute myeloid leukemia, coagulopathy and disseminated reticular coagulation is also common. And also, because these are rapidly dividing cells, you may have a lot of metabolic derangements. We'll talk about a little bit later on, but you have problems with your phosphorus and uric acid and potassium and with renal function. So this is just a picture that shows somebody having a bone marrow aspirate. So in kids, the most active area with productive marrow is the pelvic bones or the vertebral bodies. It's a lot easier to access a pelvic bone than a vertebral body. And so most of the time when we do bone marrow evaluations, it's either through the posterior or anterior iliac spine. Typically, this is showing an aspiration where we use a needle to go into the marrow cavity and to aspirate out marrow contents. Sometimes you have to do an actual biopsy, which is a little bit different needle where we core out a core specimen out of the center. You can use the specimens from there, in particular, to get your diagnosis, as well as to grow cells to cytogenetics on the leukemia samples. Sometimes there will be kids who will have enough blasts on like their regular peripheral blood where you can send it off for special testing and get your diagnosis that way. But to get good genetic samples, just what everybody would try to get a bone marrow on. For kids that have acute leukemia, you also need to do a diagnostic lumbar puncture because acute leukemia can go into the spinal fluid. So, going through specific types of leukemia. So, a really important one to know is ALL, so acute lymphoblastic leukemia. This is important to know because it's the most common cancer that we see in children. This one disease makes up a quarter of childhood cancer. Common is a relative term because there's still only 25 to 3,500 cases a year in the U.S., so a lot less than breast cancer or lung cancer in adults. In Oklahoma City, we probably see about 20 to 30 new cases a year. This makes up about 3/4 of pediatric leukemia. While the peak age of diagnosis is like in younger children, age 2 to 5, you can see it all the way through adolescence. It's one of our success stories in pediatric cancer. It's one where we improved the cure rates where it used to be an unsurvivable disease to now where more than 90% of kids are cured. So most commonly what we see when we look in the bone marrow or sometimes on the peripheral blood is you see these large blasts. They're much larger than regular red blood cells or normal lymphocytes. Normal lymphocytes should be the size of a red blood cell, and these are much, much bigger. They're also very homogeneous. You don't see differentiation, and so that's the sign of leukemia. So, some basics about ALL therapy. Most of ALL therapy is outpatient, so they get chemotherapy in the clinic, chemotherapy at home by taking oral medications. Treating the spinal fluid is very important. So we do spinal taps and give chemotherapy into the spinal fluid on everybody with ALL. And knowing the length of treatment. So this is treated differently than other cancers where ALL treatment lasts a long time. It lasts for 2.5 years for girls, 3.5 years for boys. We used to use a lot of radiation therapy to treat the spinal fluid, but with better spinal tap medicines that we can use, we don't do cranial radiation as much, except for certain kids that have a lot of spinal fluid disease at diagnosis, and for some kids have a subtype called T-cell ALL. And bone marrow transplant isn't used nearly as much anymore. We kind of reserve it for some very high-risk patients who don't respond well to treatment or have unfavorable genetics, or for kids who have relapses of leukemia after treatment. Yes?
Why do you treat boys longer than girls?
So to prevent relapse in testicle, so we do, that's a site of relapse. We don't do intratesticular therapy, so we do another year of systemic therapy. For the moment, there's some discussions about for some of the lower risk patients about decreasing the length of therapy for too. So the most common subtype of ALL is B precursor subtype, and this makes up about 80% of childhood ALL. So these were originally going to become B lymphocytes, were going to become plasma cells or antibody secreting cells, and they stay in the immature state. It's associated with some of our best cure rates of over 90%. We use this whole complicated algorithm looking at their age and diagnosis, their genetic risk factors, how they respond to treatment to kind of come up with these groups, risk groups. We can kind of see here, we have some groups like our low and standard risk patients where we have cure rates in the above 95%, even our high risk and very high risk we're generally above 80, 85%. So the bulk of the remainder of childhood ALL is T-cell ALL. And so T-cell ALL, T cells, if you remember, kind of grow and develop and mature in the thymus, and so T lymphoblasts also do that. So these kids often can present with these large anterior mediastinal masses. And so you can kind of see on this X-ray here, if you look at the far left, you kind of see this abnormal looking X-ray. Heart should look like a lowercase b. It looks like a pentagon or a quadrilateral. That's not right. And you can kind of see on the lateral there, this is all really in the anterior mediastinum. That's where the thymus sits. And you can see here on a CT scan about how this kind of does airway compression on the carina. For whatever reason, there's a predilection to see this more often in teenagers and much more often in males than females, almost 4 times as many times in males than females. And often you have a high white count in diagnosis. Because of all the mediastinal issues, it can be tricky at diagnosis. They can have airway problems, can have problems with pulmonary venous return. Sedation can be risky for procedures because willpower is all that's holding open the airway, and if you, even if you're intubated, this is below the carina, so if you intubate somebody and sedate them, it's still going to snap down, you're not going to be able to ventilate them. So a lot of times we have to use peripheral blood to make a diagnosis, or do non-sedated spinal tap, bone marrows, or lymph node biopsies. The good things are these melt away with chemotherapy, so you don't have to do a big surgery or emergent radiation or anything like that. And so it's important to know that, for older kids who've never had trouble breathing, who suddenly have trouble breathing, you might want to think about an X-ray or something like that. So we'll talk a little bit more about it later. So moving on from ALL, we'll talk about AML, which is makes up a large chunk of our childhood leukemia, about another 20%. So AML is a leukemia of the myeloid, monocyte, erythroid, and megakaryocytic or platelet cell lineages. In kids who have inherited bone marrow problems like Fanconi's anemia, this is the most common leukemia that we see. As well, when you hear about kids or adults who got chemotherapy in the past and then developed leukemia later on in life, it's more often AML. Cure rates for AML unfortunately lag behind the cure rates for ALL. Our cure rate's only about like 50 to 60% currently. Part of it is due to the therapy is very strong, and so there's a high rate of death due to infection, due to side effects of chemotherapy while on treatment, as well as a high rate of relapse. So AML has a kind of very heterogeneous kind of appearance underneath the microscope. These blasts, as you can kind of see here, are much larger than lymphoblasts. They have a lot of granules, just like neutrophils will have granules. There's this classic type, if you look in the lower left, called acute promyelocytic leukemia, or APML, that has these, if you look in the cells, these kind of stacked granules, what we call outer rods. And if you look in the lower right-hand corner, there's a unique type of AML that we see almost exclusively in kids who have trisomy 21, which is like a platelet precursor megakaryocytic AML. So unlike ALL, which is predominantly treated outpatient, most of AML treatment is done inpatient, where we do 4 to 5 cycles of very high-dose chemotherapy. Kids will stay in the hospital because their blood counts will drop, and they'll stay low for several weeks, and that's a huge risk of infection, and so they stay in the hospital until their blood counts recover due to that. So they spend the bulk of like 5 to 6 months in the hospital. There's a unique subset we talked briefly about called APML, which is the blast response to differentiating agents like retinoic acid or Calatra, as well as another differentiating agent called arsenic trioxide. So these kids actually respond to a very different regimen and have often need a lot less chemotherapy or no traditional chemotherapy, just these differentiating agents, and have cure rates that are over 85%. Bone marrow transplant is used more frequently in AML than in ALL, especially if you have a child who develops AML due to bone marrow failure syndrome or due to prior chemotherapy. So kids with trisomy 21 have a couple of unique features related to AML and myeloproliferative disorders that you should know about. So about a third of neonates who have trisomy 21 will have something called TMD, or transient myeloproliferative disorder. These babies will have like a little bit higher white count than normal and may have circulating blasts, have some organomegaly, and often otherwise look well. This is typically self-resolved by about 90 days of age. There are some kids that will have really high white counts and can have like liver problems, lung problems, and kidney problems, and may actually need some low-dose chemotherapy to prevent organ destruction. About a third of these kids who have TMD will go on to develop AML. And so when you take care of kids who have trisomy 21, there's like a lot of screening labs in addition to like your thyroid function and make sure they see, ear, nose, and throat with the predisposition for ear infections. There's CBC monitoring, especially when they're young, more frequently for their risk of developing leukemias. So the AML that kids with trisomy 21 develop is unique because they often develop this rare platelet megakaryocytic precursor, and their leukemia is much more sensitive to chemotherapy than other forms of AML. And so these kids, especially if they're young, less than 4 years of age, have cure rates of well over 90%, while other kids with AML is supposed to be about 60%. So there is some myeloproliferative disorders that we see in children. So chronic myeloid leukemia, or CML, it only makes up about 1 to 2% of childhood leukemia. In adults, it makes up 20% of adult leukemia. Most of the time we see CML is in older kids, like teenagers. And this is due to kind of an overproduction all along the whole like granulocyte or neutrophil cell lineage. And it's classically associated with this one genetic malformation, this chromosome called the Philadelphia chromosome, which is a translocation between chromosome 9 and 22 that leads to this tyrosine kinase that's overproduced. So CML, kids will often present with very minimal symptoms, but will be found on CBC to have a very high white count. And when you look at the differential, it almost looks like you're looking at bone marrow. You see neutrophils, you see myelocytes, metamyelocytes, promyelocytes, monocytes, and a few blasts here and there, which is kind of what you look at in a healthy bone marrow. You have like the proportion of everything. You'll often have splenomegaly, you'll often have normal hemoglobin and platelet counts as well, and often are otherwise well apparent. For years, it used to be that CML had a very poor outcome, and everybody had to get bone marrow transplant. But since they came up with molecular targeted therapy with tyrosine kinase inhibitors like imatinib or Gleevec, that's changed how we approach things, so we typically do that more often. But there's some risks and benefits to weigh out. In adults, getting a tyrosine kinase inhibitor for 10 years when you're 70 till you're 80 is one thing. When you're giving it to somebody who's 15 and they're going to be on it for 50 or 60 years is another thing. And so bone marrow transplant is still an option to consider depending on the situation. So another myeloproliferative syndrome that's unique to young children is something called JMML, or juvenile myelomonocytic leukemia. There's increased risk for developing this in kids who have some inherited syndromes like Noonan syndrome and neurofibromatosis. This is a pretty aggressive disease where you have to do bone marrow transplant. If you don't, generally kids won't live a year past diagnosis. And even with transplant, the cure rates are pretty poor. So moving on from leukemias, we'll talk about lymphomas. So leukemias are blood cancer that starts in the bone marrow. Lymphomas start in peripheral lymphoid tissue and lymph nodes. And they then spread to other parts of the body. And this is our third common malignancy after acute leukemias and malignant brain tumors. And the two big subtypes, one we call Hodgkin's lymphoma and one we call non-Hodgkin's lymphoma. So what should a lymph node worry you about for a lymphoma or something malignant? Ones that are rapidly growing, ones that stay big for more than a couple of months, ones that don't shrink to antibiotic, ones that shrink when you give steroids for them, which you shouldn't do usually most of the time, but then get small and then grow back up, and steroids treat lymphomas. If you have a kid who's got big lymph nodes and have fever, weight loss, and fatigue, or if they have lymphadenopathy like in the mediastinum or the neck that's so bad that you want to give steroids, then you should think about lymphoma. Supraclavicular lymph nodes are also very worrisome because they're kind of almost like the periscope of like something in the mediastinum poking its way out. Really large lymph nodes, more than 3 centimeters, and any that are hard, fixed, immobile, or irregular. So imaging can be important to kind of get an idea about the extent of disease. So you can see here in the top image, this is the CT of the neck that shows like on the right side you have these markedly enlarged lymph nodes as opposed to the left side. The lower image is what we call PET-CT, which looks at metabolic activity. This child's brain is working as it's supposed to be, it has a lot of energy uptake, but all those lymph nodes there on the right side normally should look at the left side where there's not a lot of metabolic activity. And so these are lymph nodes that are involved with lymphoma. Because these are rapidly growing and dividing, some of these, especially non-Hodgkin's lymphoma, you can have a lot of electrolyte abnormalities. Ultimately, you need tissue to make your diagnosis, and you also have to evaluate the bone marrow. The lymphomas can go into the bone marrow, and non-Hodgkin's lymphomas can also go into the spinal fluid. So, in younger children, this kind of shows you like kind of the curve about how the incidence of the different lymphomas happen and change over time. In younger children, non-Hodgkin's lymphoma is more common, and then as you get older, Hodgkin's becomes more common. So, Hodgkin's lymphoma typically presents with kind of painless cervical lymphadenopathy, and also can involve supraclavicular nodes. A lot of kids will have mediastinal nodes when they're diagnosed, The history can often be pretty vague. They may have lymphomas with a slower growing lymphoma, it may be for several months or even up to a year with mild symptoms. About a quarter of kids will have what we call these B symptoms of advanced disease. So fever, drenching night sweats, where they're like changing their clothes in the middle of the night, and an unexplained weight loss. So Hodgkin's lymphoma is treated with chemotherapy and often with radiation to the involved areas. And if you kind of look at this from a recent kind of chemotherapy protocol data, for like our lower risk patients, we do less therapy. For our higher risk patients, we do more treatment blocks. We're trying to currently for some of our lower risk patients or patients that respond well to treatment, to try to spare radiation to these kids. And with some of the other risk groups, we're trying to tailor our drugs to have less toxicity. Because the cure rates are great for Hodgkin's, it's over 90%, but there's a lot of late effects. So radiation to the chest and to the neck can cause risk of thyroid problems, thyroid cancer, breast cancer in the future. Some of the chemotherapy in particular is gonadal toxic for men, as well as some of the chemotherapy has cardiac and lung side effects. And so we're trying to find the best balance of keeping the good cure rates, but trying to minimize the side effects. And so right now we're working particularly hard on trying to get rid of radiation for a lot of the younger kids, or a lot of the better, lower risk patients. So non-Hodgkin's lymphoma makes up the other types of lymphomas. So it's a little bit more heterogeneous population. There are several common subtypes. This is the most common malignancy we see in kids who have HIV/AIDS. Generally, unlike Hodgkin's, which is treated with chemotherapy as well as radiation, non-Hodgkin's lymphoma is typically treated with chemotherapy alone and rarely require radiation. So lymphoblastic lymphoma is one that's one of the more common ones that we see. This is about a third of childhood non-Hodgkin's lymphoma in children. It's kind of like acute lymphoblastic leukemia's like cousin, because underneath a microscope they look identical, but they behave a little bit subtly different. In ALL, B precursor subtype was the most common, with lymphoblastic lymphoma, T precursor subtype is the most common. And these kids present often with large anterior mediastinal masses, and it can kind of mimic asthma. And so these can be, besides the airway issues and things like that, a lot of these kids, will sometimes the reflex can be, somebody who's wheezing, we should hit them with steroids. And steroids can actually, while they can treat lymphomas, can also cause a lot of electrolyte issues and things like that, and can cause something called tumor lysis syndrome. And so that's why if you've got somebody who's got a history of asthma who comes in with wheezing, treating with steroids is perfectly appropriate. If it's somebody who's older, who's never had a wheezing before, and is not responding to things like albuterol and other things you do for asthma, then it might be time to step back, think a little bit more about doing an X-ray. These kids are treated similarly to kids with ALL. So Burkitt's lymphoma is another common form of childhood non-Hodgkin's lymphoma. This is our most rapidly growing malignancy, where it doubles every 24 hours. Up in the upper picture is what we see kind of called the endemic or African variant. This is highly associated with EBV infection, and you'll often see kind of pictures like from Africa where kids have these large kind of jaw or neck masses. In the U.S., we more often see abdominal masses. They can be still quite big. That's not clearly associated with EBV. While these can cause a lot of problems early on due to rapid growth, a lot of electrolyte issues, the cure rates are really good with hospital-based chemotherapy. So the other non-Hodgkin's lymphomas are large cell lymphomas. There's some that are B-cell lineage, which are kind of similar to Burkitt's, but maybe a little bit less aggressive, treated similar manner though. And then we have these rare subtypes called the T-cell lineage ones. Sorry, double click there. So moving away from hematologic malignancies, we'll now talk about brain tumors. So brain tumors are the second most common cancer that we see in children. It's our most common solid tumor that we see in children. Compared to adults, they have very different locations where you see them and different subtypes. In children, we see more low-grade gliomas, low-grade astrocytomas, and embryonal tumors. In adults, more often, we see high-grade gliomas and meningiomas. Adults also have a lot of metastatic brain tumors. They're like metastatic sites from like the lung or somewhere else. That's a less common site of metastasis for children. As well, in children, 2/3 of pediatric brain tumors are what we call infratentorial, which is like the cerebellum and the brainstem, while in adults, the majority are supratentorial, which is like the cerebral. So there's some localized symptoms you can see with brain tumors based on location. Brain tumors are in the tumors that are in the brainstem and the cerebellum. You can have cranial nerve palsies. You can have ataxia. For tumors that are in the pituitary gland, you can have tunnel vision, or favorite word, bilateral temporal hemianapsia. And you also have endocrine gland dysfunction. Cerebral tumors can cause hemiparesis. In a young kid, young children who are like less than a year of age, typically are ambidextrous. If you're 6 months old as a righty, you should worry if there's something else going on. If they're right-handedness, or if your kid's a righty and becomes a lefty, you have some concerns there. Cerebral lesions can also cause seizures, and like frontal lobe masses can cause personality changes. So any brain tumor can also cause increased intracranial pressure. This could be from pressure from the mass itself on the brain, or to obstruction of cerebrospinal fluid outflow. You can see altered mental status, you can see headache and vomiting, which is often in the morning and then improves, and there's no associated diarrhea with it. You can also see cranial nerve abnormalities because as the brainstem gets pressure downward, you can have pressure on the cranial nerve. Particularly, you can see sluggish pupils, and you can see esotropia. As well, you can also have ataxia. On exam, if you have a really good panoptic, you can see the papilledema, like this kind of obliterated retinal disc. In very young babies, you can see a very obvious bulging fontanelle. And you have to be watchful for Cushing's triad, which is a signal for impending herniation. So you may have hypertension, bradycardia, and abnormal respirations, like Cheyne-Stokes respiration. So imaging, a CT scan is quick and dirty. It gives you an idea about whether you have a big bleed or whether you have, like here, hydrocephalus and a mass. MRIs, though, are better for localizing tumors. And so you can see here's an MRI that very nicely shows the tumor here in the posterior fossa below the tectum. Because they also, besides picking up blood vessels better, also can map the cerebellum and the brainstem better. So MRIs are very, very important. So this is kind of a graph that shows a little bit of distribution of our common brain tumors and kind of cure rates. So in general, cure rates for brain tumors are about 70%. For some, have a very good prognosis. Completely resected low-grade gliomas have cure rates over 90%. Our standard risk medulloblastomas have cure rates over 80%, as well as our germ cell tumors or germinomas. Unfortunately, we have other ones that have poor prognosis. So high-grade gliomas, which are like the most common ones that we see in adults, we also see in children that have a pretty poor cure rate. We also have something called this is unique to children called ATRT, which has a cure rate that's like less than 30–40%. And then diffuse intrinsic brainstem gliomas, which kind of infiltrate through the brainstem of the pons, are basically incurable. So for treatment, kind of this is a table that shows kind of all the different types, and you don't have to memorize all the specifics. But this is to kind of highlight kind of how we approach brain tumors and treatment in general. So for a lot of these, surgery is important. For a lot of these, radiation therapy is very important. Chemotherapy for some of them, like medulloblastoma and germ cell tumors, is important. It's not as important for some of the other ones. And even for kids who are cured, there's a lot of late effects, because even resected brain tumors, you're cutting into the brain. The brain doesn't like that. And so you may have long-term deficits due to that. Same with radiating sections of the brain, especially in somebody who's really young. As well, chemotherapy has side effects. So there's a lot of substantial challenges even for the kids that are long-term survivors from childhood brain tumors. So moving on from brain tumors, we're going to talk about non-CNS solid tumors in children. A lot of these, you can make a diagnosis based off of imaging. You can get an idea about whether there's a mass or something present by imaging. but you need tumor specimen to confirm what this mass is. Besides looking at the primary area or primary tumor site, you also frequently will have to look at the chest, because that's a common area for metastatic disease. And some tumors, you need to do things like bone scans or PET CTs, which look at bone and other sites. And some tumors also can go to the bone marrow as well. So the general kind of principles of staging of solid tumors are stage 1 tumors are ones that are completely resected. Stage 2 are ones that are grossly resected, but there's microscopic disease left over. Stage 3 are ones that are either just biopsied or partially resected or have local lymph nodes that are involved. And stage 4 is when you have kind of distant metastatic disease. Most commonly the lung, but it can also be like the liver, the bone, and the bone marrow. And there's a unique stage 5 for one disease called Wilms tumor that we'll talk about. So this kind of just shows on the left like a chest x-ray that shows metastatic disease in the lung, and then on the right a CT scan that shows metastatic disease in the lung. So you kind of circumscribe nodules inside the lung. And this is the most common site for metastatic disease. So some other types of, we talked about, something called a PET CT. And so on the left you see a PET CT that shows like all these areas like in the vertebral bodies that are lighting up, as well as like pelvic lesions. Bone scans also in the middle can also show where there's extra areas of activity that can be metastatic tumor. And then on the right is a bone marrow aspirate that shows this clump of tumor cells, like a bundle of grapes inside the bone marrow. There we go. So how do we generally approach solid tumors? So in general, most kids with a solid tumor will need some chemotherapy. Sometimes it's to shrink this primary tumor so it can be resected, but as well to also treat microscopic or radiographically evident metastatic disease. As well, local control to the primary tumor site is very important. And this can be either surgery and or radiation, depending on disease. As well, surgery and or radiation is important to the metastatic sites as well. So we'll start with abdominal tumors in children. So there are several common subtypes that we'll go through. So neuroblastoma, Wilms tumor, and hepatoblastoma. The common presenting symptoms for abdominal tumors are often abdominal pain, abdominal distension, may have constipation, may have vomiting and weight loss. Some kids will have hematuria, some kids may have jaundice. And sometimes it's incidentally, with some of them it's incidentally found, which is like another family member who's like playing with a kid and feels a bump that they didn't feel several months ago, and that can be a thing. So Becker-Lehman syndrome is an important thing to know, especially in primary care. This is an inherited genetic disorder that's often associated with multiple congenital anomalies. At birth, these kids have macroglossia, macrosomia, can have problems with hyperglycemia and hypoglycemia. They may have an omphalocele present at birth, and as well can have hemihypertrophy. So if you kind of take a look at this kid's leg, one leg is bigger than the other. And this is important to know because this is a condition that's had associated with increased risk of abdominal tumors and tumors in general, particularly neuroblastoma, Wilms tumor, and hepatoblastoma, where they have substantially, these relative risks are kind of times the regular population, so almost 200 times the regular population risk of neuroblastoma, 800 times the risk of developing Wilms tumor, 2,000 times the risk of developing hepatoblastoma. So kids with Becker-Lehman syndrome, when they're young, get periodic abdominal ultrasounds to screen for these tumors. So neuroblastoma is our most common abdominal tumor and is our most common non-brain tumor, solid tumor that we see in children. It makes about 10% of childhood cancer. It's our most common cancer we see in infancy. So our median age of diagnosis is 22 months, so this is seen in very young children, and the majority of cases are diagnosed by 10 years of age. These primary tumors, so the abdomen is the most common site, but it can be anywhere along the thoracic and cervical spinal cord, and they can metastasize to lymph nodes, bone, bone marrow, liver, and skin. So neuroblastoma can present in various ways depending on where the lesion is. So In the abdomen, you may feel like a hard, fixed abdominal mass. These kids often will kind of be sickly looking. For masses that are like in the high thorax and the cervical area, you know, this picture that you see at the top picture is somebody with asymmetric pupils, and you see Horner syndrome. You have ptosis, meiosis, and anhidrosis. So you have a droopy pupil that's constricted, and you have absence of sweating. Some of these tumors in the cervical thoracic spine can also cause spinal cord compression and nerve root compression, so you may have some neuropathic symptoms. For whatever reason, there's a predilection for metastasis to orbital bones, and so you may see, like this, there's a picture, the second picture on the bottom, kind of bruising around the eyes, called raccoon eyes. So when we evaluate for neuroblastoma, you often see on a CT scan, like on the top CT, this top image of CT scan, you see a large abdominal mass, and you can see all these calcified cagings inside of it. So sometimes some of these can be picked up on the X-ray. As well, there's a screening marker that you can test in the urine, something called urine catecholamines. And so we have something called homovinilic acid, or HbA, or minimal mandelic acid, or VMA. It's typically a send-out test, so it's not like it'll come back like the next day. It takes like a week or two to come back, but something that is another piece of information that, because these are frequently elevated in neuroblastoma, we can use that as a marker to see how they're responding to treatment. Neuroblastoma can go to the bone marrow, so we have to do bone marrow evaluations on these kids. As well, these tumors take up radioactive iodine, so we use a special scan, something called an MIBG scan, which takes up this radioactive iodine. So the images on the bottom, you see on the left, somebody who has an MIBG scan diagnosis, which has this mass in the abdomen, all these masses on the skull, and the bones, on the legs, and you see kind of after getting treatment where those masses have less activity. So neuroblastoma, there's some risk factors for poorer and better outcome. Histology is important, favorable, better than unfavorable. Age of diagnosis is important. Less than 18 months of diagnosis is more favorable than older than 18 months. Higher stage is also unfavorable. And then genetic tests, something we call MYC amplification. So MYC is an oncogene, and when it's amplified, it's associated with more aggressive disease and higher rates of relapse. So treatments and outcomes. So about a third of patients have low-risk disease, which is basically these isolated tumors that are favorable histology or surgically resected. Typically, you don't need any chemotherapy or radiation. We have another group of kids that have what we call intermediate risk, where they have tumors that may be a little bit bigger, not completely resectable, and these kids often do well with debulking surgeries combined with some kind of modest chemotherapy. You don't have to do like a big radical surgery to remove the whole tumor, or you need radiation afterwards in most of these kids, and they still have good cure rates over 90%. The struggle we have is almost 40% of kids with neuroblastoma have high-risk disease, and that's associated with cure rates of only about 50 to 60%. These kids get high-dose chemo for like about 6 months, big aggressive surgeries to try to remove their tumor, then do autologous stem cell transplant, radiation, immunotherapy, like a year and a half of treatment, and unfortunately still about 40 to 50% of them will relapse. So moving from neuroblastoma, we'll talk about Wilms tumor next. So Wilms tumors are the most common renal tumor in children, and it's also one that we see mainly in younger kids. Most of the cases are diagnosed by age 5. Most of the time, one kidney is involved, but about 5 to 10% of cases, both kidneys are involved. 10 to 15% of cases of Wilms tumor are in children who have known congenital anomaly syndromes. So we talked about Beckwith-Wiedemann syndrome being a big one. There's something else called Wagger, which is Wilms tumor, aniridia, G malformations, mental retardation, Denny-Strash syndrome, and then hemihypertrophy. Wilms tumor is another one of our success stories, with cure rates are about 85 to 90%. So Wilms tumor often will present as an abdominal mass in a well-looking child, with a neuroblastoma, which is an abdominal mass in a sickly-looking child. On our PEDS boards, we're always tested as a 2-year-old whose grandma hadn't seen the kid in a while, seeing the kid in a bath and feels involved in the stomach, but the kid's otherwise fine. Sometimes you can get hematuria because it's the kidney that's involved. Sometimes you can get hypertension, the kidney plays a role with that. it's less often that you see like kind of obstipation or obstructive symptoms. I mean, look at CT scans, you see this large tumor in the right kidney in these pictures here, and you look at the lower image, you see this kind of claw of normal tissue kind of holding on to the tumor, so that's called the claw sign. So Wilms tumor, when we see Wilms tumor, especially in one kidney, we attempt to do a complete nephrectomy. You can't do really sparing surgery on that kidney, and we try to avoid a biopsy. Afterwards, you then do chemotherapy to treat for any potential metastatic disease, and we change it based on the histology and the extended disease. For higher stage tumors, you may need to do radiation to like areas that have metastasis like the lung. The cure rates for Wilms tumor, I mentioned before, are very good, particularly when you have our most common histology, what we call favorable histology. These are more well differentiated, and the cure rates, even for high stage disease, are really, really good. Anaplastic histology is less aggressive and thankfully less common, and is associated with poor event-free overall survival. So, there is another type of renal tumor that we see in children, renal cell carcinoma. This is our most common renal tumor we see in teenagers. It's the most common renal cancer that we see in adults. Risk factors for renal cell carcinoma are a lot of the kind of lifestyle choices, issues like with smoking, obesity, hypertension, environmental exposures to heavy metals, solvents, asbestos. There's also congenital anomaly syndrome, something called von Hippel-Lindau syndrome, where up to half of them may develop renal cell carcinoma in their lifetime, as well as tuberous sclerosis. Renal cell carcinoma, when it's low stage, which is treated typically with just surgery alone, typically has pretty good outcomes. And higher stage disease is very, very poor outcomes. So moving on to the liver. So our third most common intra-abdominal tumor we see in children is hepatoblastoma. And this is our most common liver cancer that we see in young children. There's an increased risk in very premature kids and kids who have very low birth weight for developing hepatoblastoma. You can kind of see here, the smaller you are when you're born with your birth weight, they have increased relative risk of developing hepatoblastoma in your lifetime. There's a tumor marker, alpha-fetoprotein, that's often elevated in kids who have hepatoblastoma. It can be tricky in very young kids because neonates have a high AFP just as a rule, and then those levels should fall. So if you have kids with high levels in the mass, then that makes you think about hepatoblastoma. So hepatoblastoma, for low stage, favorable histology, fetal histology tumors, sometimes you can get away with just surgery alone, but most kids wind up needing chemotherapy in addition to surgery. Some kids, based on the location of where the tumor is, may need liver transplant, especially if you have it sitting like in the biliary tree where you can't resect it without taking a biliary tree, you need that to live. Or if it's involving like multiple lobes or multifocal, some of those kids are eligible for liver transplant or even like a directed donor transplant. And the outcomes are much poorer when you have metastatic disease. So hepatocellular carcinoma is a less common liver cancer. It's the most common one that we see in adults, but it's our most common liver cancer that we see in older kids. There's a lot of congenital risk factors, like with the inherited genetic diseases like hyperkalemia, biliary cirrhosis, like storage disease, a couple of these other things. As well, there's some like areas where you have endemic Hep B and Hep C where you have increased risk. This also has an elevated alpha-fetoprotein. The cure rates for this are poor because often you have metastatic disease and diagnosis, and even with chemotherapy and surgery, most kids are not able to have complete resection, so the cure rates are very poor. So moving away from the abdomen, we're going to talk about soft tissue sarcomas or bone sarcomas in children. So these are in soft tissues and bone. That typically kids will present with pain that's kind of new onset. If it's, often can be waking them up at night, and, kids who are ambulating may not be ambulating. And sometimes you'll see a soft tissue mass on exam, you may or may not. As well, depending on the location of the tumor, you may have some unique things. So like tumors in the pelvis can cause urinary stool retention or incontinence. Tumors in the chest wall of the rib can cause respiratory problems. Orbital tumors can cause proptosis. Biliary tract tumors can cause jaundice. Sometimes kids may present with like a minimal, like one patient of mine who just got elbowed in the arm by his brother and his arm snapped. And when he did an x-ray, there was what we call a pathologic fracture. The bone was weakened because there was a tumor in there. So osteosarcoma is our most common malignant bone tumor. It's more commonly seen in teenagers in the second decade of life. It has a predilection for the metastasis of growing long bones, so the distal femur is the most common site, but also the proximal tibia and the proximal humerus. For kids who've gotten prior radiation or have had like a genetic syndromes like Li-Fraumeni syndrome or bilateral retinoblastoma, you have an increased risk of developing osteosarcoma. On X-ray, you'll see what you go to the top picture we call a continence triangle, where you have periosteal elevation with this kind of sclerotic appearance of bone. And then an MRI is the best tool to kind of map this out, where you see a destructive bone lesion with the soft tissue component sticking out. So osteosarcoma is treated with chemotherapy as well as surgery. Typically we do about 10 weeks of chemotherapy, then we try to remove the primary tumor. These are pretty big surgeries. We get a wide negative margin around it. These aren't radiation sensitive, so we can't do a radiation to treat it. You have to do a surgery if you want to try to cure it. And as well, you need to try to do remove metastatic disease. So if you have lung masses, you need to have those resected as well. These can be pretty complicated. It used to be everybody had to get an amputation, but now with better prosthetics, we can do like limb salvage surgeries where you can have a good quality of life and still have good functioning of them. After surgery, you continue to do chemotherapy. For localized disease, the prognosis is getting better. We're now about 70%. For metastatic disease, unfortunately, it's still pretty poor. The most common site of metastasis is in the lungs, but you can also get it to other bones in the body. So our second most common bone tumor is what we call Ewing sarcoma. This is also more common in adolescents, and unlike osteosarcoma, which is in the metaphysis of long bones, this is more along the axial skeleton and the diaphysis of long bones. So this X-ray we have here shows like this destructive lesion in the right iliac crest, and you can see on MRI where that right iliac crest and ilium looks abnormal and with the soft tissue masses there. You can also be in the chest wall and the rib. There's a strong Caucasian predilection, where it's more than 6 times more common in Caucasians than African Americans. Ewing sarcoma is treated with chemotherapy and also with local control. These are radiation sensitive, so a lot of times, especially in areas where you can't do good surgery, like if it's in your pelvis, resecting your pelvic bones is not really feasible. So radiation is a better option for some of these areas. That's why radiation to metastatic sites. Just like osteosarcoma, the prognosis is much better for localized disease versus metastatic disease. Unlike osteosarcoma, Ewing sarcoma can also go to bone marrow, and in addition to like the one here. So moving away from bone tumors to muscle tumors, our most common malignant muscle cancer we see in children is called rhabdomyosarcoma. Bulk of the largest proportion of these are seen in younger kids, 2/3 from kids less than 6 years of age. This is also another one that has a heavy Caucasian predominance. And you can kind of see here on MRI the child who has some leg pain, and you see this large mass here in their quadricep. And these can be in any muscle of the body, and so they can be like orbital muscles, like your eye muscles, biliary tract muscles, any muscle. So rhabdomyosarcoma, just like the other soft tissue sarcomas, you have to do chemotherapy for our treatment. For local control, radiation is used in most cases unless it's resected up front, and so a lot of these kids will get radiation exposure. There are a couple of different histologies that play a role in cure rates being better or worse. For kids to have something called embryonal histology that's localized, cure rates are actually very good, up to 85 to 90%. Even kids who have metastatic embryonal histology or young have curease about 50%. Alveolar histology is more aggressive. Even localized disease only has curease of 60%. And in metastatic disease, especially in older kids, has curease of only about 20%. So moving away from soft tissue tumors, we'll now talk about germ cell tumors. So germ cell tumors arise from gonadal cells and gametogenesis, but they can be both in gonadal sites and extragonadal sites, kind of based on like kind of how the embryology of the fetus develops. In younger kids, they're more often extragonadal, like sites like the mediastinum, the CNS, the abdomen, and the sacrococcyx. In older kids and in adults, these are more often gonadal, so testicular ovarian. In kids who have genetic syndromes like Turner syndrome or Klinefelter syndrome, you have increased risk of developing germ cell tumors, as well as boys who have cryptorchidism or an undescended testicle. Part of the reason you have to refer them to urology is because that can predispose that testicle to developing germ cell tumor in the future. Germ cell tumors frequently will secrete markers you can also track in the blood. So yolk sac tumors will secrete alpha-fetoprotein. Choriocarcinomas will secrete beta-HCG. Some of them don't secrete. So germ cell tumor presentation can vary based on location. Ovarian tumors can often have vague abdominal pain. Something can mimic like appendicitis, or it can be even as large as where you see a palpable abdominal mass. Testicular tumors, you may feel a kind of non-tender, irregular, firm mass on the testicle or enlarged testicle. Extragonadal tumors, the sacrococcyx, because there's a lot of nerve roots that come out of there. You have constipation, urinary retention. Mediastinal masses can cause chest pain, respiratory distress. And then CNS germ cell tumors, because the location is often near the pituitary gland, that can cause problems with precocious puberty, diabetes insipidus, or SIADH. Ultimately, you have to do imaging to kind of get your extent of the disease, and then tumor markers, and then get a biopsy. So germ cell tumors generally respond very well. Low-stage tumors can often be treated with surgery alone. Higher stage tumors require chemotherapy. Radiation we only really use for the brain. Then the prognosis overall is very good for even localized as well as metastatic disease. The exceptions being things like choriocarcinoma, which when it's metastatic has very poor outcomes, or when you have brain disease. So, kind of moving away from separate cancers, we're going to kind of talk a little bit more about like complications of chemotherapy, and then kind of what we call oncological emergencies. Does anybody need a 5-minute bathroom break? Everybody okay? Okay. So chemotherapy affects rapidly dividing cells in the body. And so there's some normal body cells that are affected in addition to the most rapidly dividing ones, which are cancer cells. So the bone marrow is affected. You get bone marrow suppression, where you can't make normal white cells. And so kids will need blood-clotting transfusions like red blood cells and platelets. You have increased risk of bacterial infections when your neutrophil count is low. Your GI lining, so your stomach and your intestines and your mouth, are also constantly being replaced. And so when you have chemotherapy, you get nausea and vomiting. Some drugs can cause neuropathy of the bowel and cause constipation, and some can cause disruption of the mucosal barriers, what we call mucositis. A lot of chemotherapy is processed by the kidney and liver, so you may have organ dysfunction there. Most chemotherapy will cause alopecia. The hair follicles are also rapidly dividing. Some medicines, like steroids, can cause like myositis and skeletal muscles, and some chemotherapy like vincristine can cause neurotoxicity and peripheral neuropathy. So long-term effects after cancer therapy. There's some medicines that we know have long-term effects on cardiac function, kidney function, liver function. Some medicines we know have particularly increased risk of developing infertility. You may have, depending on if you've had like surgery on your brain or CNS radiation, you may have problems with pituitary gland function and abnormal growth. Long courses of steroids, which are like used in leukemias and lymphomas, can cause osteoporosis. Radiation can cause secondary cancers in a radiation field, as well as some chemotherapies can cause leukemias in the future. And both spinal tap therapy to the CNS, as well as radiation to the CNS, can cause problems with neurocognitive function in the future. So